Welcome back to the 76th Presidential Advisory Council on HIV/AIDS Full Council meeting. We're at that point of the agenda now for the council members to have a discussion, thinking about what we've heard over the last 3 days, from our site visits to the 2 days of meetings that we've had. I will say again, once again, just how I think amazing the presentations have been, the discussion, the community input that we've heard has been critical and something we value a great deal. So what we normally do in this part is go around from council member to council member and get your thoughts, both thoughts about what in particular you might be leaving here with today, any thoughts on what you think should be priorities, and we can then take that information and figure out how we will move forward with subcommittee work and other work. So what I want to do is actually start with Carl, and we'll go around, and Carl's going to also share some other information as well. Carl, all yours.
Thank you, John. And I think everyone knows this already, but this morning, and Jen Cates, actually PACHA member, sent this into me. The judge in Texas, Reed O'Connor, who has a history of anti-ACA, anti-LGBT cases, issued his final ruling on the Braidwood case. And that has to do with coverage of preventive services under the Affordable Care Act. And it was a sweeping ruling and nothing positive about it. And so he said that all the ACA requirement for coverage of U.S. Preventive Service Task Force recommended services is struck down and cannot be enforced. And so that includes, this is extremely important to this room because it is HIV testing, hepatitis B testing, hepatitis C testing, all screenings for STDs and PrEP. And I was just talking to a reporter and I said, for us, it's just not preventive services. This is the linkage to treatment for HIV, for hepatitis, and also to PrEP. And HIV testing is just so critical of the work that we do. So it's a very, and then there was also a challenge on the Religious Freedom Act and a violation of that. And he agreed with that for just PrEP only. And singling out PrEP violates the religious protections of this private entity. And so it's a nationwide ruling. One of the options was it just going to be just impact that one company in the plaintiffs? But no, it's nationwide. So the next step is that we need the federal government to appeal. It's Braidwood Management versus the defendant is Becerra. And so they need to, request a nationwide stay. And so this does not go into effect, and then appeal to the 5th District Court in Texas. And it will, it'll probably get argued this summer, briefed this summer, and it may very well go to the Supreme Court. But the most important thing is we need to make sure that these continue now. Remember, the same judge invalidated, the ACA, many parts of it, but there was an injunction to stop that. So the other thing is, we could appeal to insurers to continue to cover the services right now. And this is already in their rates for this year. So there's no question that, they should be continuing this. And also there are state laws as well. This is only one part of the Affordable Care Act. There's an essential health benefits as well that is coverage of preventive services. It doesn't have the zero cost sharing. So very big news, not only impacts us, but all preventive services. And just to add that my organization has retained a law firm we cannot join the case, but we can file an amicus brief. And that's what we're going to be doing in the district court. Any questions? And then we'll be looking towards, the administration. Hopefully they'll be acting today.
So definitely more to come on that. Thanks, Carl, for making sure that everybody had the latest breaking.
Did you want me to continue on my comments?
So now, yes.
I wasn't prepared for that, but
well,
but
it's never stopped you before.
I said a lot this morning already that what we're going to do and my thoughts. But I was kind of disturbed at some of the comments made yesterday that means we need to do a better job of communicating some issues, and that's status neutral, and and what that is, and how it relates to funding. And then the other issue is the relationship of ending the HIV epidemic initiative along with other programs. And but I just think that we have to address those. And we have a lot of so that's one thing. And then just as I said earlier, I really for future I really think we should talk about sex ed and youth at some point. But great meeting, field trip, I learned a lot, and the last 2 days has been extremely rewarding. And I thank all the speakers and our government partners, for being here.
Great, thanks. We'll go around and do the PACHA members, and then if we've got some additional time, if any of our federal partners want to pipe up with anything as well, that will be great. So Laura, your thoughts?
Hi, I wanted to just say I really appreciated the public comments yesterday and everything that we heard. That's so important to driving the work that we do together, and also the PACHA-to-the-People. It was nice to have it. It was my first, at least in person, and so I really enjoyed the interactive nature of that. I also really appreciated the discussion around stigma and the mental health and substance use presentations. Those are issues that very much are integrated in all the work we do at my organization and across Indian country. And I am looking forward to the next meeting being in Arizona. I just wanted to share that. I really look forward to having the discussion about the unique relationship of tribal nations with the federal government, just being able to explain how our health system works, to be able to share our unique status, and that tribal nations are not considered a racial ethnic group. They're actually considered, they have a political status in federal Indian law. And so sometimes when we talk about equity, we actually will say trust and treaty obligations to tribal nations before equity. Like, we totally, of course, want equity, but first and foremost, there's a trust and treaty obligation to tribal nations. And that goes back to kind of what I mentioned earlier about funding and just making sure that tribal nations and American Indian and Alaska Natives are at the forefront. So thank you.
Absolutely, thanks. And I appreciate your leading with what our Arizona time will be, and wanted to actually officially allow someone else to lead on that. We'll be making sure we look for the right invites to respect the sovereignty of our tribes. And so the intent is for us to focus on tribal health issues and HIV. So thanks for that. Let's see. Leisha.
Thank you. Yes, it's been a great couple of days. The site visits are always exciting. Very good information. One takeaway for me was the organization, Us Helping Us. I do like the fact that they have a research program for the participants there. And of course, considering I work with research, it's a great addition for the communities to be able to participate and even lead some of the works within research. So that was definitely a plus for me. And listening to Dr. D's update on MPOX today, one thing that stuck out was the mention of cisgender women being at 2.9% of new cases. And while that may seem like a small number, considering the 95% for cisgender men, I would love to see, more education around that for all communities, because again, while that number is pretty low, it's not. Anything over 1% is high as it is. But it would be great to hear or see more education around that, as well as seeing the differences between the new cases and the vaccinations between African American communities. So again, I would just love to see more education around access for all populations, as well as more education when it comes to MPOX.
Thank you. Leo.
Thank you. So first, I just would like to share a few thank yous. So, first to IBR and REACH, us helping us, and La Clínica del Pueblo for hosting us, and also to all of our presenters. The theme for me for this meeting, based on everything that's been shared, is community power. After hearing that from Calypso Makafani, and also ally support. Just thinking about all the presentations that we've heard from our federal partners, for example, presentations that we've heard from leaders of different organizations that continue to advocate every day. I was brought to the thought of what our purpose is here with PACHA, and we are here in service, to people living with and affected by HIV. I really feel like this group is really focused on ensuring that we're hearing from community and that we're acting on what we're hearing from community. So one thing that we heard from community with the PACHA-to-the-People and then with the public comment is needing to have continued discussion about molecular HIV surveillance and cluster detection and response. So I know that that is something that remains a priority for the Stigma and Disparities Committee, and something that we plan to continue discussing. I also found the bidirectional learning panel to be very both inspiring and informative. I think there continues to be so much that we can learn from international partners in regards to best practices that we can employ here. And I think that there needs to be kind of more discussion around that and more opportunities for us to continue to hear from global partners to inform our work locally. I'll stop there. Thank you.
Thanks, Leo. Justin.
I will echo a lot of the comments that Leo's offered. Just to put a finer point on the commitment that we have to really continue work on molecular HIV surveillance, cluster detection and response. I'm excited to really dive into what Director Phillips brought to us in our meeting next week for the Stigma and Disparities Subcommittee. So that is a strong commitment and ongoing work. So excited to continue to do that in collaboration with folks around the table. I think I also personally was really moved by the presentations today. As someone that doesn't work heavily in the substance abuse sort of space, it was really, really informative. And so I think there has to be some kind of work streams that follow up from that. So I haven't quite formulated my thoughts about what that looks like exactly, but I know that that's something that we need to take a more focused look at as we move forward. I want to echo kind of what Leo lifted up around the concept of community power that we heard in the global bidirectional learning panel yesterday. I think that is just really central to everything that we do here, and just to make sure that we are kind of coming back to that as a focal point. And I think, throughout all the presentations, we did see the importance and the barriers that stigma creates. And, I think from the presentations today, just seeing how much provider bias gets in the way. I mean, these are not things that we haven't heard before, but I think it just is a reminder of, how important it is to really get at stigma in the work that we do. So that's certainly going to be a focus of our committee's work, but really I think everyone around the table is committed to eliminating stigma, combating racism, and making sure that, we have actionable steps that actually produce results around those issues. I think those are some of the main takeaways, but I thought this was a really productive meeting. I'm really disturbed by what Carl has just brought into the space. I continue to be disturbed by what we're seeing happening in Tennessee and other places around the South with respect to attacks that are being made on our trans siblings. And so I know that that isn't necessarily something that that we can do as a PACHA to address. I know that we all wear different hats, and so I think it's just important to remember to bring that energy and what we heard into those other spaces, so that we continue to make change for the communities that we're accountable to. I'll stop there.
Thank you. Ada.
No, it's really tough to go behind my colleagues here, and really want to echo some of the comments that have already been made. What an awesome 3 days, 2.5 days that we've had with the site visits and then with the panel discussions. And then, as I was thinking of things to add that were different that had already been said, of course, the emphasis on molecular surveillance, moving forward and seeing what that is actually going to look like. I just wanted to take this opportunity to truly highlight the importance of, the community health centers, of what I do every day, and, actually taking a look at how best can we, use these opportunities within these centers to, not only with HIV testing and treating, and also with prevention, but as we heard today with opioid use disorders. And we saw this at our site visit, how you have opportunity to, touch people's lives by getting individuals into care and using that to actually treat the whole person, and having this opportunity to provide comprehensive care is something that we really need to help and to assist organizations moving forward. And with that, the information we just heard from Carl, as a clinician, I was able to many times go around and talk to my colleagues and say, these are recommendations. These are recommendations from the USPSTF. And now, we have this barrier that's going to really prevent us from moving forward in many ways. And I think we need, as a advisory council, to do all we can to, really put a stop to this, because we're going to end up losing a lot of lives, going to end up losing a lot of opportunities to get individuals into care and to hopefully, move forward with ending the HIV epidemic, along with other epidemics that we're seeing. So that's all I have. Thank you. But it's been a great couple of days.
Thank you. And I want to bring in from our online, Vincent, if you are still on the line, would love to hear your thoughts.
Hey, John, I'm still on the line. So I want to start by, can everybody hear me okay?
Yep.
I want to start by saying I think the meeting was phenomenal. I think what I appreciated most about the meeting was the depth of conversation, and that I really sensed that there were some tough issues that we were collectively sort of talking about, and I think it was handled really, really well. Just a few highlights and things that I want to share. I love that we're going to be focusing on youth. I think folks know that's an area that I feel particularly strongly committed to. I was sort of, like everyone else, pretty depressed, Carl, by what you shared in terms of the policy context. So that's obviously something to keep an eye on and for us to think about as a group. I want to zoom in on two things that I think were pretty striking about the meeting. One, really liked that we talked about substance use and overdose deaths. Part of what I'd like to highlight is that from my read, and I'm certainly not an expert on substance use disorders, but my read of that literature suggests that the majority of people who are living in our country, and I actually referenced 37 million people who are not receiving treatment, who in fact are diagnosed with a substance use disorder. When I last looked at that literature, there's about a little over 41 million people who have a substance use disorder. So if I just look at that sort of basic math, it means the majority of people in our country that have a substance use disorder are not in treatment. And I think we need to focus in on that, particularly as it pertains to HIV and the synergy there. I do want to spend a second talking about the CDR and the MHS. And I want to be very thoughtful in my response and my way of articulating kind of what I've been thinking about. So one, I just want to sort of publicly say that I actually do support a lot of the messaging that I heard yesterday and today. I think this idea of health equity and ensuring that every tool that we have available is being used to fight the epidemic is right up all of our alleys. I think that the idea of really trying to better align where there are outbreaks with available, response is an important, tool from a public health point of view. Here's where I'm still a little bit stuck, and I would ask for us to keep the conversation going. And I guess, Harold mentioned that I think it was Harold that mentioned that there might be a framework that would be forthcoming. And as I was thinking about the comments, I was sort of thinking about dimensions of a framework that, I would like, us to consider. So one, what is it that is unique about the CDR and the MHS that gives us information that we would not otherwise have? And I'm emphasizing the word unique, that we would not get in some other way. And in addition, can we focus more on the benefits? And I'm really happy to see that CDC has been putting up case studies like what was discussed with Detroit and Atlanta, and that there are new things coming, the repository of literature, et cetera, that was discussed. But I think we need more of that. We need more emphasis on the benefits. And we also need to hear more about the risk and ways of mitigating that risk. And the last thing I'll say on this is that, we haven't talked a lot about the outcomes. We've talked about some potential strategies and alignment of services, but really the hard evidence as to whether or not this approach is working. And I don't want to be sort of pot stirrer, but I'm going to raise something that in terms of my own reading of literature, and I may be wrong, but my read from the MMWR reports is that some of those clusters have actually not gotten smaller, they've gotten larger. And so given that, I think we need to ask ourselves, is there a need to refine our approach? Maybe we weren't intervening, maybe we're evolving in our understanding of what best to do, but somehow we have to reconcile this health equity messaging with looking at data and outcomes. Thanks for listening, guys.
Thanks, Vincent, and appreciate the sort of detailed thinking you're giving to this, as we all will do as well. Wendy, if you're online, we'd also love to invite you into the conversation. Sounds like she had to move on. Daryl, thoughts from you?
Certainly. It's very good to be back in person. I want to, two things that strike me, particularly as I'm listening to the comments. First, I want to acknowledge, Laura, what you said, and Carl, what you said. The necessity to honor the original trust and treaties and the obligations. And Carl, what you said, the erosion and the loss based on a court hearing, those things too come together for me, which say I'm not surprised at what happened in the court hearing. We have, as a country, a history of not honoring and respecting commitments and promises that were made. And much of the discussion today resurfaced key elements of that. And when I was watching yesterday, and I think that what strikes me, and I know sometimes I can be kind of a renegade on these issues, is that if this body is going to do its work well and advise with integrity and honesty, this body must continue to interrogate at the level of the original sins and violations that have occurred and been perpetuated in order for us to start an active process of moving to a better place. that if we only allow ourselves to live in a space of accommodating the inequities, then we really don't do justice to what it means to be in an advisory role to those who say through the actions of their policies that they intend to accomplish change. And I think these kinds of discussions, as hard as they are, they're not partisan. They actually are at the heart of a democratic experience that calls us to task at this moment to speak these difficult realities with clarity in the face of things that would not want us to do that. And so much energy is being expended to cap the voices. It's clear that the voices are a threat. And so we actually should listen to that. People wouldn't spend this much time and energy if we were not a threat to their comfort of the way things were, and that we have an obligation to continue to advance to the way things ought to be.
And Marlene.
And I really just wanted to thank you, Dr. Wheeler, for lifting that up, because it really undergirds a principle that I wanted to speak about. And as a person with lived experiences of many kinds, today was particularly poignant. October 15th of 1992, I entered into substance abuse recovery and have been able to maintain sobriety for 30 years. Reminder that I need to get that on the HIV.gov website in my bio, because I do think it's important for communities to really know the representation of the voices who are, speaking on their behalf and making recommendation from, our equally shared lived perspectives. And I also wanted to just express my continual frustration when we are intentioned by our mission to listen to the voices of community and their realities and experiences, and tend to dismiss them in ways in which we may label them as misinformed. They may not have pieces of information that we have, but that's our responsibility to ensure parity. It is also important for us to remember that many times they are speaking from their experiences and how some of this work is played out on the ground, which is why I really honed in on Dr. Cooper's comment around what happens at the federal level. Some of you know I used to carry around a chart with me that talks about funding and programs and the ways in which they trickle down to my local reality in Houston and Harris County. And I remember sharing that with the Office of Management and Budget many years ago, and they were stunned. So what happens between some of these federal conversations and what ends up happening on the ground? And status neutral approaches is a good example. And how the intention behind it, the science, the vision behind it is absolutely in direction of where we need to be. And as we heard today, there are some programs that have been doing that forever before we put a label on it. But how it gets interpreted by leaders in key roles makes its way to making bad decisions around programs. So I don't think we should dismiss that without further exploring. So I guess my recommendation is that we really do spend some time engaging in status neutral implementation examples and the ways in which some leaders embedded in states and local, not just public health departments, but community health centers, and all of the ways in which we expect that these resources get used for the benefit of our local communities. We should hear more about that because, quite frankly, I do think there is some active misunderstanding of the intent and approach but not by community and what they see and experience every day. It really is about the administration of it all and the unintended consequences. I've been telling, and my CDC colleagues know, because I've said it to most of them, about the ending of the PS 2010 NOFO, ending the HIV epidemic, and the idea that just those few sentences that came out from our federal government. I have been around a while, and I suspected this might be an alignment that would help create some efficiency, but that's not the way it read when it gets sent to my public health director and finance director and my procurement department at the city level. They want us to begin closing down as if the grant is closing down. So sometimes even in communication and expectation, how that gets played out as it gets closer to the local level is certainly unintended consequences. So I just want us to be mindful as we think about that. And for stigma and disparities, and I will be quiet, the idea that, you know, people who experience substance use and the provider stigma just stunned me. I almost just fell out of my chair when I saw that slide, but every slide that came up was just stunning to me. And that this be something that maybe we look at from the stigma point of view regarding substance use in particular, and the ways in which providers not only are hindering access to necessary treatment in and around that, but also how it has impacts negatively on HIV. So those are the things I wanted to share, and which is probably most of my closing.
Can I respond to something you said, Marlene? Something that we didn't get to yesterday in our bidirectional learning conversation, that because we just ran out of time, but I think something you brought up, Marlene, about the provider stigma. I feel like there's several different streams of work that could emerge from that, because I think there's certainly work that has to be done within the provider training and, you know, making sure that we're making our clinician workforce culturally humble in a way that is not stigmatizing. But I think the larger issue is that providers are learning that stigma from just their interactions in culture and society at large, right? Where that stigma is coming from their lived walk of reality, right? And so I feel like when we talk about stigma, we often think about it in the context of the systems that we have some type of purview over, but those stigmas come from outside of that, right? And so there also has to be some type of work that addresses that, because sure, we can sort of control maybe what happens, you know, not really, but like we can sort of control what happens within the systems that we control, right? But folk learn this from outside of that. And so what are we doing in trying to shift sort of the relationship between politics, culture, and people so that that stigma does not continue to be perpetuated, right? And so that's a harder and heavier lift, but I feel like that's actually where the work is, right? And so so I feel like we also have to think about what our role is within that larger kind of piece, you know, and I think that goes with all the kind of anti-trans bills that are that we're seeing, because that is both creating stigma, but also it's an embodiment and codification of the stigma, right? And so there has to be a way to push back against that, both within public health and medical systems, but outside of that. So I just feel like I wanted to make sure we thought something about that as well.
So, Justin, just piggybacking on what you're saying, you know, and I mentioned this previously, the importance of implicit bias training. So many times we forget about that. And especially on the physician side, we really have to be actionable in and making sure that that's done. And how can we do that? A lot of medical schools now are trying to be intentional in adding that to their curriculum, in addition to, DEI and all these things that, sound good on paper. But again, it begins, as Justin said, early on, and having that opportunity to identify one's bias is really important. And how can we, as an advisory body, try to really hone in and push that concept forward? Because we can continue to try to build a workforce, but if we build a workforce that is not culturally humbled and culturally sensitive, we talk about, and I get frustrated when I hear culturally competent. That is just checking a box. And that does not mean that you have the ability or the willingness to be humble. And I think it's important that we, push forward the concept of cultural humility. And I think these are things that we can help moving forward.
Great, thanks. As I reflect on this meeting, certainly lifting up what you all said as a collective is incredibly important. I also, as I reflect sort of on this meeting or 3 days, the work we've been doing as a group for some time, is just reflecting on our federal government employees. We do share the same vision to ending HIV transmission, supporting people who are living with HIV/AIDS, those who are at risk for many things in terms of all the social determinants of health and the health challenges. And the work we want to do to support people to be able to live their true lives and their true selves. And, our federal employees are also in that lived experience as well, in acknowledging that working in this space, I'm thankful for what they do and for the sacrifices that they make, as well as the sacrifices that all of the folks in our nonprofits and our health departments are making as well in doing this important work, which is often mission, driven from that place deep within our hearts. And the work that we have as a council to both support their work and push when we need to push, right? So I appreciate that, and that we're able to have that kind of dialogue with folks who are our friends. I think when we do that, when we sort of push on our areas of uncertainty or disagreement, we best serve the people we're here to serve. And I appreciate that. I also sort of want to appreciate just some of the wins. We've have a lot of challenges out there. We've articulated some of those. I've expressed some frustration with the challenges out there as well at this meeting. But I think that we can also, celebrate that we're at a place where it looks like we are on the cusp of getting a blood donor policy that is based in the reality of today, where the science has gone, and where many folks have been pushing for some time to get us to. So assuming that moves as we think it will, that is an important win. Narcan being approved as over-the-counter is another important sort of policy win, and we've got to celebrate these things as we go along the way. Work in MPOX and moving forward and being at a very different place than we were about a year ago, right? But also realizing it's still a threat. And the work isn't done. As a matter of fact, the work right now is of urgency so that we do prevent another outbreak. So appreciating all of that and trying to hold all that together as we move forward to not sort of lose sight of some of those wins along the way. And that those wins certainly often start from community pushing. And it occurs with the folks who are in our government trying to do right by the people we serve. So I appreciate that very much. And we'll take away all the other things, the work we have to do as well, but don't particularly want to focus on that at the very moment. That happens in about 15 minutes after this meeting where we start that work. I did want to give any federal partner at the table, if there's anything you would like to contribute to this conversation, this is work we do together. And so fingers are pointing towards Harold. And Leo, you wanted to add something before the federal partners?
So I just wanted to mention, as we talked about the national PrEP program and working towards getting funding for that, that we definitely have not only an access problem, but we also have a utilization problem in regards to PrEP, particularly among Black MSM and Latinx MSM and transgender and nonconforming people. I was looking at the data in California, where I'm based, and we have a state PrEP assistance program. And only 4.5% of PrEP users in 2021 were Black men who have sex with men. And there was that data that came out from CDC that 9% last year of Black MSM nationally are on PrEP. So as we think about increasing access, we really have to look at what are models that are actually working to increase utilization, or we will end up in a place where we have all this access and we still have Black MSM left behind. So that's one priority I would like us to think about for stigma and disparities, to hear from Black and Latinx-led programs and organizations, particularly around what has worked for them in reaching their clients to get them on PrEP. Thanks.
And just to build on that, I mean, I think that there have also been some really important thinking by Black PrEP advocates about, you know, what would work best for Black communities. And so I think we want to make sure that we're learning and listening from those models and examples as well as we think about what a national PrEP program should look like. Because I think you're 100% spot on. I think I remember being struck by that information when we were in LA for the PACHA meeting, because, you know, living in a non-Medicaid expansion state, seeing in California, which we look at as sort of the land of milk and honey in many ways, where you have kind of all these resources, and it doesn't look much better in terms of access for Black MSM as we have in Georgia, which has none of the things that California has. So as we think about designing, you know, the system, we absolutely have to get that right. But I think there's more to it than that. So we absolutely will be making sure that that's a big part of our work.
And certainly support that. I guess my cross-cutting comment to some of this is, folks, when are we going to learn? We do this every time. And we keep supposedly relearning the same lessons, which means we're not learning them, right? We have got to figure out in the public health system and beyond that we don't have to sort of recreate this every time, right? Like, so how we get there, I don't know, but enough. All right, there are ideas. And so Harold, I think we're going over to you.
Okay, thank you very much. I think we hear you loud and clear that it is not about buying bulk medication. That's not going to solve it. And so we are thinking about what are the ideas and how do we do this without creating a new set of barriers, but taking into account everything that we know. I want to thank PACHA for the day, PACHA and the speakers, the presentations, the OIDP staff that put together the site visits and all the rest of it. I also want to acknowledge that tomorrow is Transgender Day of Visibility. And I want to lift up the fact that you all did, I think, a great job in making sure that our transgender community was seen in various ways through the site visits, the discussions with providers, the agenda items, our presenters, our public comment as well. President Biden's proclamation for the day is also, I think, up on the White House website, and speaks to a number of the issues that we know are facing the community when it comes to inclusion, safety, and justice and their rights. So I hope PACHA members get a chance to look at that. I think the things that you all have mentioned are right on target in terms of things that are part of the bucket list, that if you go back and you look at what we said ONAP was going to focus on for these next 6 months, it kind of aligns pretty nicely. I think one of the things that I took away from this meeting is that there is so much work that still has to be done. I will say I am very concerned that some of the things that the community is focused on, we may have to do a better job of working with them to create better understanding of some of these pieces, because we're at a point in time in our country where sort of if there is daylight between us and them, it might be perceived as dangerous and not helpful to the things that we're trying to do. And I just need to put that out there. When we have folks that are questioning a status neutral approach, and yet we're having presenters who are telling us we've been doing this for years because we've had to in order to meet community and their needs, but yet we have leadership that is confused about that. When we talk about the syndemics and we're having discussions about resources, does that mean resources are going to go away from people living with HIV to focus on those who are negative? That is not helpful to what we're trying to do right now. And when we're trying to make a space at the table to address all of these needs, which are coexisting and concurrent within our communities. I think at the same time, I've also heard, because this is like the second week, because we had AIDS Watch last week, we had the FAP, now we had you all. So my list is growing. I heard people who were concerned about ending the HIV epidemic. What does that mean for people living with HIV? And had to actually take a pause and talk about what it means for quality of life, and what we really talk about when we're talking about ending HIV as a threat, as a public health threat. That means that HIV becomes not a factor in your life, but a condition that is manageable, and you can go on and live your best life. That's what we're trying to achieve. But somehow that message is getting lost in this as well. Then I also heard a lot about quality of life, and I look forward to working with both the NHAS and the EHE committee on ways to think about some of our mainstream programs, both at the federal level, but also the state and local level, and how we make space for not only people living with HIV, but those that are at risk. When we sort of talk about this endemic, and we think about housing, and we think about youth that are homeless and at risk for HIV, how do we make space within those housing programs for them so that they can meet their needs? And also, how do we use ONAP in the White House to also create some spaces and some dialogue between those programs within those departments that traditionally have not been involved in this work? So when you go back and look at the slides, some of this definitely aligns, but I feel like the work of PACHA really supports some of the thinking initially about what the priorities should be. So thank you all.
Thank you, Harold. And Kay.
Thank you. I'll be really brief. I just want to say, first of all, thank you, Leo, because I've been preaching a long time, and Dr. Harrison knows we're like, it's more than access. And I feel like I'm banging my head sometimes. I said, COVID, let me just go back, and because I heard you, John, loud and clear. Let's start there as an example. So thank you, Leo, for bringing that into space. And I just want to say thank you to everyone around this table. The discussion, those crucial conversations, they're twofold. One, I'm thinking about, I heard status neutral. There's a lot more that we've got to unpack with that. Combating stigma. We've talked about stigma. I've been on PACHA, executive director. We talk about stigma. I was like, we are still having. So what does it look like when we talk about it differently? Because those conversations are still unfolding very much in the same way, unfortunately. I was struck by what we need to do with youth and what we're not doing with youth, and how we bring our youth into that space. And so it's an opportunity where these crucial conversations in PACHA make me think about what is it that OIDP can do. And so looking at my team to talk about what can we do about youth. And Vincent reached out to me late last night. So I'm going to be reaching out to Vincent because I'm using all my subject matter expertise wherever it comes from. And so I will be reaching out to Vincent to have those conversations of what that might look like. And then also had a conversation with Alicia about Black women in HIV. And having those conversations and where can my office lead in that space and utilize the PACHA members at this table as we have those conversations, but starting with a small group and saying, what is it that we can do? Tim mentioned this earlier, we're a policy shop for the most part. We're not driving programs, but how do we fill the gaps? How do we be a fire starter if that is the will? And so I walk away from the PACHA seat, but then also from the OIDP seat of how we can help in that space. And just want to thank John and Marlene for wonderful facilitation. And Professor Wheeler, as I'm going to say, I was like, when am I taking the class? Thank you.
Mine's fast. So I just want to start by saying I'm going to add nothing to what Kay and Harold have said, because what Kay and Harold have said is the truth and how we have to be and where we have to go. I just wanted to add one really important rah-rah, one cheerlead. HIV is the key. HIV is the way, and we should be on the same page, that the way that you address chronic infectious diseases and acute infectious diseases is really using the same tools. It requires political will, community engagement, and science. Never forget, HIV is the key. And in every setting that we are in the world that we circulate in, we need to remind folks that by supporting the HIV infrastructure and the syndemic infrastructure, you're preparing the country for the next thing. I come to you as the MPOX coordinator, and I'm looking from the outside in right now. And just never forget that you are the key. Your view, your programs, your engagement, your vision, your resolve, and your engagement is the key for this country to keep the fires burning, make sure that public health and infectious diseases continues to work in a way where we respect and love the populations that we serve. So whatever Harold and Kay said is true, just never forget, you are the key.
Thanks for that. I also want to just bring into the room again the people who've been virtually with us. We appreciate you both for listening in, the work that you do out in community every single day, living your true lived experience as well. If there are other things you want us to be thinking about or you want to reinforce anything you've heard here, feel free to please write us at PACHA@HHS.gov. That's PACHA@HHS.gov. I will just say thanks to everyone who helped make these meetings possible. There are many folks who that includes, and just thank you. Thank everyone who got you here, including your teams back wherever you are and who are doing the work for you while you're here, thanking them and appreciating them as well. And I'm going to turn it over to my amazing co-chair to more eloquently wrap up.
And I will defer first to Dr. Harrison. It looks like you want to make some closing comments.
I'll be real quick. Just a couple of takeaways from me, and I can going back to Kay in the office about just a few things. Always sort of looking at, from our vantage point, how does OIDP fit in all of this mix of this? And there's a few things that really sort of hit me from the site visits and the couple of days of work. One was really listening to the bidirectional conversation, and then also the presentation by Dimitri on impacts really sort of had me sort of thinking about sort of reactive versus proactive public health, and where the conversation yesterday was really about anticipating that we coexist with systems of inequity. And so there's no surprise when COVID hits or when impacts hits that, it was, oh my God, there's disproportionate impact. well, yeah, we know that's going to happen. And so, and the same thing what happens when new biomedical tools are introduced. Oh, not all communities are going to get it equally. Or when there's some new sort of, infectious disease out there again. And so how do we begin to sort of think ahead of that? And so we're anticipating, and I think the monkeypox approach was a really good example, how you're sort of anticipating that there are going to be these inequities. And so how do you get ahead of that? And sort of waiting for it to happen and then say, oh my, we got disparities and inequities. So that was the first sort of, and the bidirectional conversation was really sort of touching on that. And so I thought that was really key. And then the other thing was sort of, well, two things. One was, and I think Harold and others have sort of talked about it, is this sort of framing and language thing where sometimes I think our concepts and our language are getting ahead of where we're actually implementing them in the real world. And so we're using terminology like status neutral, it's endemics and all this. And folks are like, what is that? Or they're like, what is the harm to me when you bring this to my community? And I think we need to do a better job of really communicating and messaging what these things are ahead of time before we start saying, oh, we are now adopting status neutral approaches and syndemic approaches. So that's one thing. And the other thing is, I think Harold was sort of touching on it too. I'm a little concerned that there's bifurcation between work on prevention and working through PrEP or EHE to end the HIV epidemic, and concern about people currently living with HIV. And I know some of these are old conversations from back in the day too. It was like, where is your focus? Are you concerned about me who's living with HIV? Or are you concerned about those who don't have it, who might be affected? I think we need to be very careful about how we draw attention to these things and that we're not sort of neglecting one or prioritizing one more than the other.
Ditto. So I just wanted to close by saying, if anyone wants to come and work with me in Texas, I'd be happy to have you. George is looking, and so just a nod to all of the challenges, ongoing, persistent challenges, but the resilience in some of these communities. And I'm hoping that we do, as we work toward designing and building our engagement in Texas, that we think through calling on community partners and allies who have been successful in these extremely volatile and violent environments, because I do think there is a lot to be learned there from people who have been having to struggle and fight and still somehow make way and make space for good, strong health outcomes in those kinds of communities. And then I just finally, in closing, just want to give thanks and recognition to Miss Angela Ross. She was the front desk receptionist at Reach in Baltimore, and some of us were able to remark that her nameplate actually read Director of First Impressions. So thanks to Angela for all that you do, and I will call us to a close. We are adjourned. Thank you.
Produced by the U.S. Department of Health and Human Services.